In this sketch, we're going to talk about what happens when you don't have enough platelets. Thrombocytopenia, in other words. It's not only platelet number that matters, though, as there are both acquired and congenital defects in platelet function that can lead to some pretty important clinical consequences. So it's all platelets from here on out. Get ready to talk about these little buggers until you're purple and blue. Which is also a sign of easy bruising due to a platelet defect, so probably would get that checked out. Oh, and one more thing. Rule number 1. There's no crying in platelet disorders. At Sketchy, we always illustrate platelet function around home plate. And in this scene, we're going back to World War II, when Major League Baseball was on the brink of getting shut down for good. That is, until a few major league owners got together and brought in women's teams from around the Chicago area to form a league of their own. This whole sketch is going to revolve around thrombocytopenia, or a lack of platelets. Thrombocytopenia is defined as a platelet count less than 150,000 per microliter, which should clue you into how benign thrombocytopenia can be. In fact, it's often just discovered incidentally on lab testing, and frequently, we don't have a good reason for the abnormality. Fortunately, while we define thrombocytopenia as less than 150,000, your bleeding risk doesn't rise until your platelets get down below 50,000, and spontaneous bleeding doesn't really happen until you're under 20,000. Just goes to show that your body has tremendous reserve to make sure random bleeding doesn't occur. I want to quickly mention the important coagulation study here, and that's bleeding time. Low platelet count means low clotting ability. Ergo, an increased bleeding time. Now, this is not a very sensitive, or reproducible, or convenient test, and really just involves taking a shiv to your patient. But bleeding time is still sometimes used when identifying patients with severe hemostatic disorders. So forget about PT and PTT since the coagulation cascade is not the issue here, and just focus on platelet count and bleeding time. There are a million known causes and clinical consequences of thrombocytopenia. Well, a million-ish. Fortunately, we can put the different causes of thrombocytopenia in 2 major categories. 1, decreased platelet production, or 2, increased use or destruction of platelets. On the destruction side is immune thrombocytopenia, abbreviated ITP, previously known as both immune thrombocytopenic purpura or idiopathic thrombocytopenia purpura. ITP is not a specific diagnosis, but a group of pathologies with one underlying similarity: antibody-mediated destruction of platelets, illustrated here by that broken immunoglobulin-shaped bat pointing towards a cracked home plate. These autoantibodies often target the glycoprotein 2b3a receptor on the surface of platelets. That's 2 balls and 3 strikes. Game over. As a side note, numerous other autoantibodies against platelet surface glycoproteins are also thought to be involved, including those targeting glycoproteins 1b9, 1a2a, 4, 5, and other various letters in Roman numerals. IgG-coated platelets are eventually phagocytized by macrophages in the spleen, reenacted by this little leaguer here, as she tosses those used plates into that macro cage. In children, the overwhelming majority of cases of ITP are acute, primary, and idiopathic. Well, we say it's idiopathic, but we have a pretty good idea that acute ITP in children is caused by an abnormal autoimmune response to a viral infection. It usually presents between 2 and 5 years of age and has a slight predominance in boys. Symptoms usually pop up a few weeks after the viral infection, enough time for your immune system to screw up and start ramping up production of autoantibodies. Keep in mind that we're eating up our platelets here. So ITP will classically present with what's called a platelet-type bleeding pattern. The same type of skin and mucous membrane bleeding was seen in von Willebrand disease and DIC. In von Willebrand disease, we lost platelet function. In DIC, we were using up our platelets because of excessive clot formation. And now, in immune thrombocytopenia, platelets are getting outright destroyed. The ensuing thrombocytopenia can lead to bleeding in the skin, which presents as petechiae and bruising. Watch out for mucosal bleeding as well, which can show up as a nosebleed. This is similar to the bleeding that ensues after receiving a healthy serving of chin music from the pitcher. You know, after getting Sean Beaned at King's Landing. To diagnose ITP, the patient's platelet count should be less than 100,000, although it's typically significantly lower, with no abnormalities in hemoglobin or white blood cell count. Remember, this is solely a platelet problem. The peripheral blood smear should look completely normal as well. This includes the platelets, which will look normal in size and appearance, You just have fewer of them. Fortunately, ITP is usually self-limited in children, lasting about 3 to 6 months before platelet counts rise to greater than 150,000. Also, patients at low bleeding risk often don't require any treatment. Just some good old-fashioned watchful waiting. More severe cases, however, with severely low platelet counts can cause spontaneous or prolonged bleeding that is significant enough to warrant treatment. But before we get into treatment, let's talk about adults. In adult patients with immune thrombocytopenia, the initial event that kicks off autoantibody production is not always clear, and a vast array of infectious and immune conditions have been implicated, including HIV, hepatitis C, lupus, leukemia, and drug side effects, to name just a few. We've drawn in our recurring chronic grandfather clock in the dugout, because in adults, immune thrombocytopenia is more often a chronic disease rather than an acute episode. ITP tends to favor young women, so look for the 22-year-old woman who comes in with multiple episodes of nosebleeds and easy bruising for months, but who is otherwise completely normal. Just like in children, severe hemorrhage and spontaneous bleeding episodes are rare and associated with markedly decreased platelet counts. Also, like last time, diagnosis of ITP in adults requires isolated thrombocytopenia with no other abnormalities on testing, including normal red and white blood cell numbers and morphology, as well as a normal bone marrow biopsy, if one's performed. Now, we're talking autoimmune here, so when it comes to treatment for ITP, corticosteroids and IVIG are your first-line options. At Sketchy, corticosteroids are symbolized by that recurring eerie moon face, evoking an image of the moon phases that accompanies steroid overuse or excess. And IVIG is represented by those antibody keys held by the groundskeeper. IVIG is exactly what it sounds like. Apparently, just administering a bunch of immunoglobulins to your patient can confuse the immune system and inhibit autoantibody production. These therapies are usually reserved for patients with clinically important bleeding. If symptoms persist, treatment options include splenectomy and immunomodulators like rituximab. Why splenectomy, you ask? Remember that in ITP, IgG-coated platelets are phagocytized by macrophages in the spleen. So remove the spleen, and you remove the primary site where platelets are getting gobbled up. Despite being the most common cause of thrombocytopenia, ITP is a diagnosis of exclusion and requires vigilance in making sure the thrombocytopenia is isolated and that no secondary causes, such as infection, malignancy, or autoimmune disease, are to blame. All right, time to move on to our next immune-mediated cause of thrombocytopenia, heparin-induced thrombocytopenia, or HIT. You remember heparin, right? From way back in Sketchy Farm? Heparin is always represented by a heparin hunter, using traps to kill some factor X foxes and thrombin thrombivores. We are blocking the clotting cascade, in other words. And this does not come without risk, as up to 1 in 10 patients will develop heparin-induced thrombocytopenia, a serious and pretty ironic complication of anticoagulation therapy. HIT comes in 2 flavors, creatively named HIT type 1 and HIT type 2. HIT type 1 is usually of little consequence, as it's a transient, mild thrombocytopenia that usually requires nothing more than observation. HIT type 2, however, can lead to some serious and often life-threatening complications. HIT type 2 is caused by the formation of autoantibodies against a complex consisting of platelet factor 4 bound to heparin. This is all illustrated at first base. We've got a heparin hunter sliding toward a glove with the number 4 on the side. This represents platelet factor 4 binding to heparin. After 4 or more days of heparin exposure, the risk of forming autoantibodies increases. These autoantibodies attach not only to this complex, but also to a receptor on the surface of platelets. This is shown at first base, which will be the platelet in this scenario. Take a close look at those cleat studs. The Y shapes are meant to evoke an image of IgG molecules. The variable domain is pointed up, as if binding to the platelet factor 4 glove, which is attached to the heparin hunter. In the other direction, the Fc region of the antibody is bound to the surface of the platelet. Yep, the platelet actually has receptors for the Fc domain. Weird, right? So now these renegade autoantibodies have attached everything together, which has several consequences. First, platelets are activated and degranulate. This is when platelets release their stored contents into the circulation. Just like Dottie who, after the last out has been called, throws her arms in the air and degranulates with joy. We've also added that factor IV glove because platelets release platelet factor IV as they degranulate, leading to a positive feedback loop producing even more antigens for those HIT antibodies to bind. It's a vicious cycle. Platelets also release molecules like ADP into the local surroundings, triggering platelet aggregation and clot formation. That's right, we're administering heparin, an anticoagulant, only to cause clotting. Imagine that these flying dirt clods are little mini thrombi forming throughout the circulatory system. While venous thrombosis is much more common, the massive procoagulant effect caused by HIT can lead to arterial occlusion as well. Venous thrombosis usually involves the extremities. We're talking DVT here, which can lead to pulmonary embolism. Arterial clots, on the other hand, can lead to myocardial infarction, stroke, organ infarction, and even death. This is one of the mechanisms underlying the thrombocytopenia seen in HIT. Platelets get consumed by this runaway clotting process, depicted here by the dirt clods covering the plate. The major cause of thrombocytopenia in HIT, however, is due to phagocytosis of antibody-coated platelets by the reticuloendothelial system. You see, it's not normal for platelets to be coated with antibodies. A lesson we learned in immune thrombocytopenia. Macrophages in the spleen, liver, and bone marrow notice these abnormal platelets floating by and proceed to gobble them up. To diagnose HIT, you must first start with the right clinical context. That means you're looking at a patient who was recently started on heparin, generally in the past week, although rare cases of HIT have occurred in patients who were weeks to months removed from their last heparin exposure. Interestingly, HIT is much more likely to occur in patients treated with unfractionated heparin compared to low molecular weight heparin. Check out our heparin hunter sketch from Sketchy Farm for all the deets. For now, just remember the risk is pretty low, around 2% for unfractionated heparin and 0.2% for low molecular weight heparin. Once you've got the right clinical context, now look for the classic symptoms and signs. New onset thrombocytopenia with a drop in platelet counts in a patient who's been on heparin in the past 5 to 10 days. That's a red flag, my friend. There may also be more subtle systemic symptoms, such as fever, chills, tachycardia, or dyspnea. The appearance of a new thrombi or skin necrosis is also diagnostic. However, hopefully HIT is on the differential before these severe symptoms present themselves. Treatment for HIT, in other words, should be started before the appearance of thrombotic symptoms or antibody testing, due to the devastating consequences a delay in treatment could cause. Speaking of treatment, anticoagulation is key since HIT is all about clot formation. Obviously, heparin's out of the question. Instead, anticoagulation with a direct thrombin inhibitor, such as argatroban, should be started immediately. That no intrudin sign is there to remind you of the rudin suffix common to a couple of the direct thrombin inhibitors, including bivalirudin. And that big gator should remind you of the other direct inhibitors that share a gatrin somewhere in the name, such as dabigatran. While mortality rates used to be as high as 20% for HIT, now that we're on the lookout for it, we've been able to identify and treat HIT much earlier in its course, significantly decreasing morbidity and mortality. All right, let's move on to the final group of thrombocytopenic syndromes, dubbed thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, abbreviated TTP and HUS respectively. The overly complicated words don't stop there, though, as TTP and HUS make up a spectrum of diseases that are referred to as the thrombotic microangiopathies. The thrombotic part comes from the fact that both diseases involve diffuse platelet activation, hence the diffuse gathering of spectators lifting that platelet into the air. Huzzah! Or hussa, I guess. You know, HUS and all. Careful though, before you get too handsy with those platelets, because diffuse platelet activation leads to diffuse clot formation. This thrombosis leads to the two common features of both TTP and HUS. First, there's a consumptive thrombocytopenia. In other words, your platelets are getting used by all those clots forming. This is illustrated, yet again, by those dirt clods covering up the plate. Even though the thrombocytopenia in TTP and HUS can be severe, bleeding usually doesn't occur. Moreover, most coagulation-related labs are normal, except for the thrombocytopenia, of course. Excessive clotting also leads to a hemolytic anemia due to shearing of RBCs as they pass through microthrombi formed in small blood vessels. This is called microangiopathic hemolytic anemia, or MAHA, and is illustrated up on the foul ball post. See that microangiopathic mesh of vessels? with dirt clods interspersed. This is meant to evoke an image of microthrombi forming within small vessels. Any baseball, or red blood cell for that matter, that tries to pass through is going to get shredded. Expect to find some schistocytes on that blood smear, a sure sign of MAHA. Remember from our creepy sketch at the Peaceful Night Hotel that hemolysis inside the vessel is called intravascular hemolysis? All the pertinent lab findings we covered then are also applicable in the setting of MAHA. As RBCs spill their contents into the vasculature, expect to find an increased serum LDH and unconjugated bilirubin, the latter of which causes jaundice. Look for some free hemoglobin to show up in the serum as well, with the corresponding decrease in haptoglobin. Also keep in mind that teabag that Norman is eerily steeping as he greets his surprise guest. A teabag is our recurring symbol for increased reticulocyte production by the bone marrow, as your body attempts to keep up with the high RBC turnover. Okay, now that we've highlighted a few of the shared features of HUS and TTP, I want to point out a few distinguishing characteristics, starting with hemolytic uremic syndrome, by far the most common form of thrombotic microangiopathy. Over 90% of HUS cases are caused by enterohemorrhagic E. coli, abbreviated EHEC. So on the wall in the back, we've got an ad for E. coli. Why drink any other flavored carbonated brown water when you can drink the first flavored brown carbonated water that comes to mind? That's right, E. coli. Why say why when you could say, why not? Children with HUS will typically present with the symptoms of EHEC infection, abdominal pain, vomiting, and bloody diarrhea, hence the whole enterohemorrhagic part of EHEC. The characteristic bloody diarrhea is symbolized by that red stool. EHEC infection is most commonly caused by ingestion of undercooked meat or unpasteurized dairy products. Check out our sketchy micro sketch for all the poopy details. In this scene, it's not EHEC that we have to worry about, however. It's actually the Shiga-like toxin that it produces. Yep, that's the Shigella she-gorilla from Sketchy Micro. And yes, she's here to remind you of the Shiga-like toxin, which enters the circulation from the bowel and induces capillary endothelial damage, as evoked by the flaking paint sloughing from the wall. Endothelial damage results in platelet activation, and, well, you know the rest. The prototypical pathophysiology of the thrombotic microangiopathies follows, where diffuse microclot formation in capillaries both consumes platelets and forms a web of fibrin that shreds red blood cells. Look for those schistocytes on the smear. Now, we've only mentioned two parts of the classic triad that characterizes hemolytic uremic syndrome. We've got clots eating up our platelets causing thrombocytopenia. We've got hemolytic anemia, re-emphasized by that popping balloon in hand. And lastly, we need acute kidney injury, which we've tried to convey at second base. Looks kinda like a cracked kidney, doesn't it? That's our recurring symbol for AKI. See that red glomerular knot? In hemolytic uremic syndrome, an important site of microangiopathic thrombosis formation is the renal glomerulus, where all that damage to the glomerular capillaries impairs the normal function of the kidney, leading to acute kidney injury. In addition to being the most common microangiopathy, HUS is also the #1 cause of severe acute kidney injury in children. HUS typically presents in children younger than 5 years of age. Now, I'm not going to rehash lab findings, as those were covered earlier when we discussed the shared characteristics of TTP and HUS. I do, though, want to mention one more little detail. One of the most important things to remember about HUS, and a favorite of test writers, is that treatment of EHEC-associated HUS should never include antibiotics, which could actually make the disease even worse. Why is that? Well, just imagine the antibiotics killing off those pesky EHEC bacteria, which happen to be fully loaded with Shiga-like toxin. When all of these bacteria break open at the same time, an overwhelming tsunami of microangiopathic toxins hits the body, which makes all of the patient's symptoms worse and can even precipitate complete renal failure. All right, it's time to dive into the other end of the TTP-HUS spectrum. While HUS is primarily a disease of young children, thrombotic thrombocytopenic purpura is almost always seen in adults, usually young women. The defining characteristic of TTP is a deficiency of atom TS13. As depicted by the number 13 jersey worn by Adams that's being thrown into the stands. We're going to focus on the acquired form of TTP, since it's vastly more common than the hereditary version. Acquired TTP involves the development of autoantibodies against the atom TS13 protein in circulation, which leads to its destruction. When more than 90% of atom TS13 has been destroyed, the clinical symptoms of TTP begin to show. In other words, get ready for some clotting. Atom TS13 is normally responsible for cleaving large von Willebrand factor multimers. In the setting of an atom TS13 deficiency, however, large von Willebrand factor multimers stick around in circulation. I mean, just look at how huge that sign is. These large von Willebrand multimers are more likely to start linking platelets together, activating them. You know, all that coagulation stuff that von Willebrand do. All in all, intravascular coagulation occurs at a much higher rate, especially in small vessels like capillaries. The diffuse microthrombosis seen in TTP leads to a clinical picture very similar to HUS. This time, it's classically described as a pentad. Start with the triad of HUS, which includes thrombocytopenia as clots consume your platelets, and hemolytic anemia as RBCs get shredded by said clots, that's MAHA. And thirdly, watch out for acute kidney injury represented by that cracked kidney base. The acute kidney injury in TTP tends to be less severe, with anuria and complete renal failure being very uncommon. The mechanism of AKI in TTP is very similar to that in HUS, disruption of the small blood vessels supplying the glomeruli in the kidney. To finish off the pentad, we're going to add some constitutional symptoms, such as fever, fatigue, and dyspnea. And finish it off with number 5, neurologic signs. Neurologic findings in TTP can range from headache and mild confusion to transient weakness and numbness and even seizures. The mechanism behind these findings is not well understood, but appears to be related, again, to reversible damage to the small blood vessels of the cerebral cortex. Now, you don't need to see all 5 parts of the pentad in order to diagnose a patient with TTP, although the typical step 1 question will probably mention all of them. All right, we're headed into the final inning here. While ITP, HIT, and TTP-HUS all involve platelet destruction or consumption, let's instead focus on a few other ways we can decrease the number of circulating platelets. Let's say, your spleen is too big. Did you know that about 1/3 of your platelets are usually sitting in the splenic circulation? It's not hard to imagine, then, that anything that leads to an engorged or enlarged spleen will cause even more platelets to pool there. In the setting of portal hypertension, for example, whether it's from cirrhosis or alcoholic liver disease, congestion in the portal system leads to hypersplenism. The total number of platelets stays the same. It's just that if you measure the peripheral blood, the platelets will be measured low. They're pooling in that enlarged spleen. Here's another one to add to your list. What if instead of destroying platelets or hiding them away, you just stop making them? The major cause of decreased platelet production is bone marrow suppression, whether it's due to drugs, infection, or cancer, which will necessarily lead to thrombocytopenia, among a deficiency of other blood cells. So when platelets are low, take a look at other cell lines too. You might just be dealing with a marrow problem. Enough of the big leagues, though. Let's go back to the bases, if you will, to where we fell in love with the game in the first place. That's right, an empty lot full of sand, hopes, dreams, and qualitative platelet disorders.